So we have a bunch of different questions, and I have a bunch of different sort of thoughts related to some of those questions. I think maybe one that I'm going to ask right off the start, because I think it's very relevant, obviously, to the presentation that we just had, is Dr. Mihalko, can you talk a little bit about maybe whether or not there were subgroups of individuals within the IDEA trial that were successful? So was there a subgroup of people that were successful in maintaining their exercise after the trial was done? And are there any unique characteristics of those individuals?
So I need to start by saying, in those that came back, those were invited. This is a really important point, that not everybody came back, right? We were surprised by how many. I have it written here somewhere. I think it was around 70 that came back, something like that. But then it all come back. So then you have to say to yourself, as a behavioral scientist, the ones who came back are the ones who are the most successful, mostly, not all, of course. And remembering that IDEA was a weight loss trial. So exercise was a part of that, an important part of weight maintenance, can get a little bit of weight loss. But that of those people that came back, because the number was smaller, we haven't looked at subgroups within that population to know. But I think that that's an important piece. And what I will say that we have looked at, though, is those with higher self-efficacy at the end of, and Eddie McCauley, there are many others that have done this, even efficacy that's about, not general, but even efficacy that's about, I can engage in physical activity while I'm in this program. If we build that over the program, it does predict those people, that subgroup of people is going to do better over time. But would they do even better if their confidence was about doing it on their own is kind of where we're going to go next.
Great, that's fabulous, and I think that's really interesting. I'm going to kind of jump on a question that was asked related to clinical practice guidelines for rehab, or clinical practice guidelines maybe for exercise therapy or exercise-based interventions. We'll maybe try to make that a little bit broader. So first of all, whether we know if there are any, and if we do and those exist, does behavioral change factor into those guidelines? But what I might also ask is, I think there's this tension between clinical practice guidelines, which is this is what everybody needs to do, and a lot of what everyone was talking about, which is, well, we need to tailor or we need to individualize based on the patient's unique barriers, challenges they have, even facilitators that they have in their life that might actually really benefit and help them to be more active. So I'm curious, and I'm going to open this up to all four of you, but I'm curious if any of you have any thoughts on, first of all, clinical practice guidelines and where behavior change fits within those guidelines. But then that tension between, okay, this is the guideline, everyone should do it, and often what clinicians will tell participants or patients versus this tailoring piece.
Yeah, maybe I can.
Yeah, go, Linda.
No, you'll both get a chance. Don't worry.
No, you go ahead, Rana. Go ahead.
I was just going to say that the one that popped into mind as you were speaking was the EULA guideline. I'm not sure if that's what Linda was going to refer to, the European League Against Rheumatism, which is a fairly recent one for physical activity in people with, I think from memory, it's inflammatory arthritis and osteoarthritis. And it's not prescriptive. It's quite, I would say, based around a lot of principles that are really, I think they're quite nice. They're ground, they acknowledge that things need to be personalized and tailored, and that all healthcare professionals need to take responsibility for discussing physical activity with clinicians. So that's a guideline that I would suggest to people to have a look at. Is that what you were going to say, Linda?
Yeah, no, that's exactly what I was thinking about. But then to add to your comment, Rana, so the guideline supports the use of behavior change techniques like motivational interviewing. If I remember correctly, the specific talk about that counseling type of approach. But what it does not, what is not so clear is that it tells you what to do with the thing. It doesn't tell you the stuff that support you to do the thing. So it tells you that you're going to, motivational interviewing is great, but how do we support health professionals to be able to deliver motivational interviewing type of intervention, or even just to deliver a session on brief action planning type of counseling? How you deliver it matters, right? So I think that's sort of maybe the next body of research that we need to create more evidence in supporting health professionals to actually do their job better.
Kelli, Shannon, any thoughts on this sort of tension between guidelines and applying them broadly versus maybe more tailored? And I, obviously aware of what Rana and Linda have brought up, and there is, I think, guidance within those guidelines for tailoring. But I think sometimes as a busy clinician, often people will go straight to guidelines. They just kind of want to read off, okay, this is what you need to do. And they miss that part, and or don't have time, and or are not supported, as Linda is saying, to do the next step. So just any thoughts on that?
Yeah, when you think about or look at the osteoarthritis treatment guidelines, they're really, I mean, other than the ones that Rana and Linda are talking about that are newer, they're pretty vague. And I think what they tell us is that it is important and we should be doing it. It does not get much granularity about how to support those behaviors, and even the details about, okay, for this patient, what's better? Should I send them to a group program? Should I just give them some resources at home? I don't think we have a whole lot of evidence base for how we integrate those guidelines into a variety of care settings, whether that's in physical therapy, primary care, gerontology. And I saw there were some questions in here about, what's different? Is there anything different than prescribing for people without OA? And I would say yes and no, because the guidelines about what is a sufficient dose of exercise and these things that Shannon's talking about, the behavioral factors, are really common for adults. So I think in one sense, what we're trying to encourage for people with OA is things that should be happening for people with all kinds of chronic conditions. There are obviously some differences for people with OA, particularly that they're dealing with pain and functional limitations that not everybody has. So obviously those things need to be taken into account. But I think the things we're talking about they're not all OA specific, and they're things that, as much as we can, we should be building on, and I think are in the research realm, building on what's known about these kinds of support strategies and behavioral interventions in the context of other health conditions, as well as general populations.
Yeah, I was going to say that same thing, Kelli, related to, I'd seen the comments, and I think it ties in well here in terms of the guidelines. And I work with cancer populations as well. And so we have the guidelines are so similar when we take apart the specifics, like you said, related to the symptoms and some of the underlying mechanisms involved in each of the different chronic diseases. But how we study the promotion of that physical activity is very much the same, and thinking of mechanisms of behavior change and what we know we can help build in our participants. I think, though, when you talk about a very short encounter, or as we see more and more physical activity interventions going online, and we all had to quickly pivot, that's the word, right, that we've all come to not love, right, with what was going on this year, and have to go online, it became very useful. In fact, as someone who was always about